Okay, I've been asked to talk to you about the biliopancreatic diversion with switch. That is a big mouthful, so if you can remember duodenal switch, or depending on what part of the country you're from, duodenal versus duodenal switch, or even DS, we'll know what you're talking about. The duodenal switch is our most powerful bariatric operation. It combines restriction, meaning it restricts how much you can eat at any one time, with malabsorption, in that it restricts how much you can absorb the food that you actually eat. And in fact, how this operation is done is you actually amputate the greater curvature of the stomach, removing about 85% of the stomach. This is a sleeve gastrectomy. I know the sleeve gastrectomy will be talked about separately as a possible standalone operation, and that actually came out of the duodenal switch as a staged operation for patients who are really large or really sick. They could do the sleeve gastrectomy first, they could then lose weight, and then 6 months, a year later, do the second portion of the operation. In the second portion of the operation, we then go down below the stomach onto the duodenum, which is the first portion of the small intestine, about an inch, and divide the duodenum at that point. Then we create our roux limb, just very similar to the gastric bypass, but instead we actually measure the length of it, starting at the large intestine backwards. So now, once everything is hooked back together, the food comes down this side. The digestive enzymes come down this other side. They mix here, and then once they've mixed, the food is mixed with digestive enzymes, you absorb your nutrients in this common channel, which in this picture looks short. It is short. It's only about 3 feet long. Comparing that to the gastric bypass, where we divide the stomach, we don't actually remove any of it, making this small pouch that holds about 1 to 3 ounces of food. And we divide the small intestine, measuring it from what we call ligament of Treitz down, the upper part, the front part of the intestine. We divide it, bring one end up to here and sew it there. This end gets sewn back to the bowel here, so that now the food comes down this limb, the digestive enzymes come down this limb, they mix here, and you absorb most of your nutrients in this common limb. This picture, it looks short. It is not. It is 15 to 20 feet long still, so there's very little malabsorption. Now, the pros to this operation is this is our very best weight loss operations. Patients lose on average of greater than 80% of their excess body weight. It is our most durable operation in that less than 10% of patients are regaining any substantial weight at 10 years. There is minimal dumping, so the stomach is actually empties fairly normally, so if patients do slip up and eat a milkshake or something like that, they're probably not going to get dumping syndrome. They may have some other problems, but they won't have the dumping syndrome. And finally, it is because of the fat malabsorption that occurs with this operation. It's the most effective operation in treating people with severe hypertriglyceridemia. The downside, there's nothing for free in this world. This operation carries with it also the highest risk. Both highest surgical risk, it is the most complicated operation that we do. And while there's controversy over how risky it is, it appears to have a risk very similar to that of a gastric bypass, but it may be a little bit riskier, although we are often doing this in our largest, sickest patients. It also has your highest nutritional risk, particularly protein malnutrition and fat-soluble vitamin deficiencies. These are usually well managed with eating properly and taking supplements. We've actually seen very little of this problem in our patient population. The other downside when you're dealing with malabsorption is diarrhea and possible foul-smelling gas. Now, if you eat too much fat, that will cause diarrhea. If you eat too many carbohydrates, it will often cause more gas. These are strong incentives not to do those sort of things, and that's what makes this operation so powerful. Number one, it is restrictive, and it restricts how much you can eat. It is malabsorptive, although not nearly as malabsorptive as more current studies are showing that patients probably malabsorb maybe 10, possibly 20% of the food that they're eating. But it helps patients because now if they do eat improperly, like eating high fatty foods or eating carbohydrates, there's a price to be paid, and they know up front, so they can avoid that by eating properly. Put all of those together, it's one of the most powerful operations that we have. Now, who should undergo this operation? Again, it can be beneficial for anybody who is a candidate for bariatric surgery. If your BMI is only 35, you still are a candidate. But the patients who tend to benefit the most are the malignantly morbidly obese, the patient with a BMI of 60 or greater. I would recommend that they consider this operation, as with these very large patients, with all of our operations, it's very hard for them to get their weight down and get down to a healthy weight. But with this operation, it's the one that's most likely to get them down. As far as comorbidity resolution, again, the gastric bypass and the duodenal switch are very similar, but the duodenal switch has a better profile. When we look at type 2 diabetes, for instance, the diabetes resolution has been well documented in multiple studies of being somewhere between 90 to 95% of all patients. Most studies in the 95% resolution of type 2 diabetes. And again, this is a very powerful metabolic operation, as this resolution of these problems go away within the first few days, first few weeks. As far as sleep apnea, hypercholesterolemia, very similar to that of gastric bypass. And if you have severe hypertriglyceridemia, it's the most effective operation of resolving those problems. All in all, a very effective operation, very good operation for the patient who is willing to be careful and eat right and take their supplements and follow up with their doctors. It can be a very effective operation. Thank you very much.